Okay,
recording in progress.
Thank you, Neil.
Okay. Okay. So you're all still there?
Yeah, we can hear you, but there is a little bit of echo.
Yes, I think there's maybe another device on.
That's better now.
Okay, right. So the first case I wanted to talk about was a little preterm infant, 27 weeks, quite well grown in utero, 991 grams, not bad. An emergency section due to maternal antepartum hemorrhage. She had received antenatal steroids and mag sulfate just before delivery, and the baby went on to a live start and had more than a minute's delayed cord clamping. Had nice APGARs and came up to the unit on CPAP 30% oxygen. There was a decision to put in a UVC for fluids, and actually ignore that last comment by 6 hours, that's wrong, but initially the baby settled into the unit on CPAP in air to 25% oxygen. So I met the baby when he was about 2.5 hours old. He just came on to night shift and handed over that he was fine and 23% oxygen, which indeed absolutely they were. But I had a look at the chest x-ray to check a UVC position. And, you know, it's striking that the UVC is sort of running up the left side of the vertebral bodies, which is odd, although I completely accept that this is a rotated film and that might have been the explanation. The baby's obviously also though got quite hazy lung fields, so I thought I'll have a look at this baby, look at the UVC position and try lung ultrasound, which is a first for me, so you'll have to excuse me on the images that they're far from perfect. So I'm just going to try and take you over now to the other screen.
So if you stop sharing there and
Okay.
screen.
Excellent. Right. Okay. So I'm not quite going to start with the lung ultrasound, but just zoom back up to the top. So a couple of images just to share, just sort of normal situs confirmed. We looked at the abdominal aorta, it looks fine. It was difficult to catch the Doppler, so I won't bother showing you them, but they were fine. And then going on to this view, we can see that you've got, actually highlighted the wrong ones, I think. There's a nice one, the IVC coming up. There we go. So you can see IVC coming up through the liver. And you can see what is probably ductus venosus coming down here with probably fluid up there, hopefully from the UVC, but we couldn't quite see it. Similar impression there, but you can't see the end of it to be sure where it is. So we just gave it a bit of a nudge and we're happy now that it's coming in there. So we're happy with the UVC position despite the x-ray. I think, you know, this baby's heart I had a quick look at, and I'm not going to share all of that, but it was just quite nice to see. I think that this baby, who had been quite nicely transitioned, had nice function, was nicely filled. We got the usual little bit, it's not on captured in this one, but a little bit of TR and MR, but quite insignificant. Interestingly, very hyperdynamic looking, I thought, and will be one worth following up because there's quite, it is early, it was about 6 hours, but a very unrestricted duct. And in fact, if you looked at pulmonary blood flow, if you looked at the pulmonary venous Dopplers, they were quite high. So that'll be an interesting one to go back and follow up. But from an RDS query or not point of view, I put the probe on the chest. Now, I have to say this was a small baby, and this was not the hockey stick probe. This was the bigger, how would we describe it? The linear, thank you, the linear probe, which has got settings for lung ultrasound, but it's maybe not the best size because it immediately became apparent that it, you know, it takes up the whole of the baby's chest. So really the idea of getting 6 different quadrats becomes immediately not feasible. So, but I was just struck that I could actually get some images, and I thought if we just look through them, you know, you can see the ribs, you can see lung sliding, and we're getting, you know, quite a lot of A lines. But we're also getting sort of intermittently B lines. So I don't know what others' thoughts on this are as to how they would have scored that or described it, albeit with the limitations of the probe. That's probably about the best of them you've seen. Down here. So I felt that was kind of an interstitial pattern and was reasonably reassured that I would just leave the baby alone, because obviously 27 weeks Lisa surfactant would be an option. So I don't know if anyone wants to comment on that at the moment, or any of those images.
Nice images, Anne-Marie. I'm really thrilled. Quite impressive images, actually. So as you absolutely described, a very nice, a clear pleural line, and you could see B lines in many areas of the scan. And if the B line is just arising from the pleura to maybe third of the space, we call it comet tail. So it's just incomplete B line. So that means there are a bit of fluid, as you already said. But
I'm glad you said that, because I did think of those comet tails. It seems to sum them up quite nicely. So that's great.
And then there is no particular evidence of RDS, so totally spot on. Yeah. Yeah.
So I mean, it's interesting. I'm going to tell you what happened next, and it's just worth having a wee think about it. So if I go back to share screen here, where's my PowerPoint gone? Got it. There we go. So remember we did those quite hazy lung fields, and I completely, you know, accept that my lung ultrasound scanning there was limited in terms of the probe and quadrants we looked at. So interestingly, this baby who by 6 hours of age should develop quite an oxygen requirement, 30 to 35% oxygen. So I decided to set up to give Lisa surfactant. And in fact, it became quite clear by the time, as you know, you're all familiar with, you get the bits and pieces out, the oxygen requirement had gone up, and actually she briefly went on to Duopap while we get set up. And we gave surfactant, and there was a lovely response. The baby went back to air at that point. So I thought that was worth sharing, and I'm not in any way suggesting that lung ultrasound actually isn't really useful and very doable, because I think it is. But I'm just slightly curious about my findings. Was it the timing? Or are there different thresholds maybe for what we might expect? We might see things that are okay and babies go on to get a milder RDS and still expect Lisa, even though you might have said that doesn't typically look like a bad RDS picture on the ultrasound. So yeah, I'm going to stop sharing that one for a minute. So I suppose the first question is, does that surprise anyone, the outcome? You've all gone very quiet.
This is Ujjwal. I mean, based on the X-ray alone, it was very typical of RDS, and yes. I'm not, you know, had the ultrasound not been in the picture, I'm not surprised at all. Very much suggestive of moderate to severe RDS on the X-ray, and you know, no surprises, the baby responded. But like you, I'm curious about the ultrasound findings, and you know, we can hear from the experts.
Sorry, Anne-Marie, I was just on the phone. By all means, I'm not the expert, but the lung ultrasound that you showed previously, obviously that was just on 1 or 2 zones, so we didn't have the full picture of the rest of the lung. Having said that, usually RDS is a universal pathology, so you don't get areas of RDS and areas of normal lungs. So that was a bit bizarre. I wonder if was there any change in the ventilation setting or any other reason?
No, No, not really. And it doesn't put me off because I think, it is partly the limitations of the probe and my expertise, but I suppose it was also quite early, 2.5 hours. And yeah, I wasn't sure. I know the score you described, Mahmood, you would talk about a score of over 6, which if you imagined all of this baby segments looked the same, which of course they might not have, you would not really get over, sorry, it was a score of over 9, you wouldn't get over
9,
that.
actually.
But then I wondered if we're looking at slightly different babies now, because we're looking at the babies that are starting off well, not ventilated. There may be babies without Lisa, you might not be going in earlier and giving surfactant. I don't know. I'm just curious. Certainly keep looking at it.
It's quite interesting case because and the beauty about lung ultrasound, you can repeat it. So it would be interesting to see the scan before the Lisa again. Was there any different,
yes, it would have been actually. I should have.
But clinically, if the baby is on 40% on CPAP, one will hesitate to give surfactant.
The decision was made, and if looking back at the first X-ray, I agree, it wouldn't be any huge surprise to anyone. It's partly why I looked at him.
Could I just ask something? Sorry.
Hello there, Maria.
Hi there. Obviously, I'm not any kind of expert on lung ultrasound, but as Mahmood said, if it was RDS, you'd expect it to be universal. But I thought your last image looked very typical of RDS. But
okay.
But I don't know if I didn't catch the first images. I had a phone call, but I thought the first one did look.
Hang on a minute, I'll just share and then I'll move on to the next one as well. So let's just share the last image again, because you might, well, you may well be right.
Maybe it was the one before that, sorry.
The one before, sorry.
No, it's okay. The one before that might have been a slightly, nope, that's interesting. Try this one.
This one, is that not quite typical?
So in this one, you could,
here, where,
yeah, so this one is probably more convincing, but you still can see background A lines. There are B lines tending to be coalescent, but it's probably you're just catching some part of, I don't know, is that the heart of the liver?
Yeah, I think it's yeah.
But you would like to see the rest, like, anterior.
I think if we get going with the right settings and the wee hockey stick probe, we'll get a much better
Thank you.
Exploration of the both lungs rather than the sort of limited views. Okay, I'm going to stop sharing that one very briefly.
Sorry, may I ask a question, please?
Please do.
Yeah, so what was the gases at that point? I mean, was there any chance to wait a bit? Because they look nice lung ultrasound pictures.
Yeah, so the gases were fine, and the gases I think remained okay, but the baby was developing quite a significant oxygen requirement and looking like he had RDS 4 hours later. So
Abhijit,
we'll
I was
learn.
interested in what Abhijit thought as well.
Abhijit, did you have some comments?
Yeah, I mean, I agree with Mahmood. We should have, we have all the lung zones. To sort of, in terms of when we talk about scores. But having said that, just looking at these images, as we know, the RDS is a global sort of phenomenon in the lung. Here we see a lot of spared areas, which are like, it cannot be like that area has got surfactant and just not.
It's not the nature of the disease.
So I'm quite like would be interested to see how the rest of the lung would have looked at that point of
it'd be interesting. And I mean, I was just excited to get pictures of lung ultrasound, so I'm not, and
but remember,
it's a very unskilled one, so I was just sharing it.
Remember, the RDSs and the TTN are both ends of spectrum, so it's a spectrum of disease.
Exactly.
And 40%, no one will hesitate to give surfactant. Absolutely not.
And I'm sure it, although the early ultrasounds are thought to be very predictive, I'm sure they can evolve as well, just like the baby's clinical condition can evolve. So it's interesting. It's not a baby where you'd have needed the lung ultrasound therapeutically in decision making, but I was just interested to try it and see what we got. So am I sharing screen again, or am I not? Can you guys, I'll share screen. Here we go. Right. Where's it gone to? It's open there. But,
That's it.
you'll find that this will get me into it if I try this.
I don't
wait.
think it will. I think it'll stay on your. It'll open it there, but so I would stop share there again.
Can you see my screen, anyone?
That's what we're seeing.
All right.
Yeah.
Okay.
Yeah, we're seeing the folder and you're trying to open.
Okay. All right. Stop share for a second.
Yeah, and then share again. Try share screen again. And hopefully
where's it gone? There we go.
there we go. There you go.
Right, got us back again. Don't know what happened. So the next case was just an interesting one that followed on that night. So a 33-weeker birth weight turned out to be reasonable, 1,800 grams. A late booker, known at presentation, I think when mum booked, around 31 weeks to have a left-sided CDH. Lung head ratio was maybe okay. There was no fetal MRI. It was known that the liver was in the chest. And before she did her fetal MRI, mum went into preterm labour. There was fetal distress, so there was a section. Well, we can come back to this if people want to, but we went for immediate cord clamping on this occasion. And the baby definitely was quite difficult to get going, was intubated immediately, took very high pressures and surfactant in labour ward to open up the lungs. We initially had to ventilate in pressures of about 35, 100% oxygen, but we managed to get things improving and we came up to NICU on about 80% oxygen, pressures of 28. And we just started on some nitric empirically on the basis that this baby had been in quite a bit of difficulty and was likely to have pulmonary hypertension. So we got a chest x-ray shortly after the baby came in. We just put in a UVC for access because the peripheries were quite poorly perfused and shut down. So you can see here, this one shows the UVC going in. And as is fairly typical in babies of CDH, where everything is moved and the anatomy is distorted, the UVC seems to shoot off into the right side of the chest. And it's hard to say where it is, but to most people's eyes, it looked very suspiciously well into the right atrium. And you can see a sort of closer view of the chest x-ray. ET tube position's fine, and you get a better sense of the shifted mediastinum, a bit of left lung, and some, but maybe not as much bowel content as there might have been in the left chest. So decided just to echo at that point and have a look at the hemodynamics, having started some nitric on a preterm baby, which always just makes me a little bit anxious, and to look for the UVC. So if I stop sharing that, and just going to have to change to another baby. Yeah. And Neil, how to get back onto my share screen here?
Yeah,
back
so
in
go
Zoom.
back to Zoom.
Yeah.
Yeah, absolutely. So just click on this one and then share screen again. And there we go. Beautiful. And just
Okay, so we should hopefully be into this baby's first scans. Now I have a list of ones to flick through, see how we do, but we'll just start with, I think, right at the very start, and these will always look a bit odd because everything was shifted over. So it's very clear actually in the first scan, there's a very dilated RV and a rather flattened LV with function that doesn't look great. And I've just stopped to highlight these ones. So you can just see that a little bit more clearly. Just looking sort of at the left ventricular outflow, it's not bad. The velocities are a wee bit low, but not too bad, I think is what I was thinking. I was quite surprised there. But looking at TR there, get it more clearly later on, but TR of at least 3 meters a second. And then just looking a bit more at the LV. It's a bit, you can see things look a bit thickened there. It's not quite so bad there, but I think just trying to see what I've highlighted here. But there it looks pretty underfilled and unhappy there, and 19 we can just get a sense in quite a lot of the views that just the sort of function up at the apex and the whole thing doesn't look great, and the whole thing just looked quite desynchronous. The 10, 22. Just moving on to the right side, you can see it all looks very dilated, and you can see now this UVC is starting to appear, but it's actually just coming into the right atrium, so it's not as far in as we might have thought. Just looking for a few more. And you can kind of interestingly get it coming through this sort of odd IVC approach, but it's not really as embedded in the right atrium as we might have thought. And then just looking at back to ductal views. So it's quite difficult always when you've got a lot of, when you get elevated pulmonary pressures. You can just see, I think it's the eye of faith, the sort of, because most of those right to left, the duct in there. It is open, not so much on that one. I'm going to jump up now to this one. And you can just see there's a bit of bidirectional flow across the duct. And whilst there's a fair period of time where it is left to right, the velocities left to right are very low, and we've got significant velocities right to left. So sort of fit with this baby with a bit of bidirectional flow, which fits with the picture. We had saturations in the kind of low 90s pre and post ductally on our nitric, but essentially there are suprasystemic pressures. But actually the right-sided Doppler velocities were all nicely maintained. And there's a beautiful picture somewhere of the RV and RA with TR, but I'm not sure if I can find it right now. So essentially, we decided to put that baby on to, left it on the nitric of 10, gave some volume, which was FFP, because we were a bit concerned about some bloody aspirates from the NG and the risk of this baby bleeding, and started some low dose adrenaline and milrinone because the blood pressure at that point was okay. As the day went on, blood pressure sagged and we got a pre and post ductal gap. I needed a bit more adrenaline and milrinone. But in fact, now a few days later, the baby's ventilating beautifully on a minimal BP support, and FiO2 right down to about 25%, and is going for a surgical repair. So I don't know if there's a lot of images here and it's sometimes hard to pick out which ones to show you, but is there anything anyone wants to ask about it? Are y'all still there?
Yeah,
Still there?
it's nice images, Anne-Marie. I was struck the right ventricle was hugely dilated, isn't it?
Massively dilated, yeah, if you go back to the start. So I mean,
and was kind of pushing the septum to the other side.
So it's, yeah, very flattened LV because of it. And you can see the atrial septums pushed right over. This, in fact, yeah, it gave it quite an odd appearance to start with, especially in the middle of the night.
Absolutely.
But yeah, I mean, I think there was a significant degree probably of RDS initially as well, and things have settled really nicely, much more nicely than you might have anticipated. So I think we've got a good outcome, despite quite a difficult start in labour ward with very high pressures to get going. We were just able to come back very quickly.
It's a nice one.
There's a nicer picture of it somewhere of a lovely sort of good 3 millimeters TR for a small baby is quite good going, but did have the potential to recover nicely, which is quite interesting.
Yeah.
And you can see a decent LPA somewhere, which I think is often encouraging.
Yeah. That's a nice case. Did you get some lung ultrasound pictures for that diaphragm?
I didn't do that. I don't think I did. No.
Be
Lots
nice.
to do. I know. It was a long night. This was one of many. Got some
Absolutely.
cranial ultrasound, and no, I don't think I've got some liver. I didn't go for the diaphragm. I've possibly not picked out the best pictures actually. So it was interesting. I think it was just that reassurance that we were going the right way, starting the nitric on a slightly prem baby, not pushing it up to 20, but just giving things a bit of time to settle. And it worked out quite nicely. And the line is, as we might have suspected, actually in an okay place. We came back a little bit. But it gives you an odd impression. At first, I almost thought we got a transposition, but it was just the...
This is a subcostal view, isn't it, Anne-Marie?
Yeah, I think it was subcostal. That
beautiful.
But yeah. So yeah, I mean, it just looks massive, but has actually done very well. And I suppose actually, maybe the thing to do is to very, very quickly see what his most recent.
And I think I agree with you about the nitric as well, because you have a degree of biventricular dysfunction, and if you give full dose of nitric, that might not help.
Yeah, I mean, the LV definitely looked, and maybe not captured properly, but it looked very oddly desynchronous in the way it was contracting when we looked at them. So this is current. It will play. I think this is done on the 4th. So things now look much more balanced.
Yeah, completely different now.
Yeah, so we've still got that significant TR though, but it does, the whole function looks much better. So it's just about giving that baby a bit of time. Yeah, which was good because he wasn't going to go on to ECMO. So
nice one.
Okay. So yes, fairly straightforward, the sort of images you'd all get. It's not a masterclass in pulmonary hypertension type 1, but just reassuring that we were doing the right things, I guess. So anyone else, anything they want to ask about?
Yes, please, if possible. I'm just a bit concerned about use of pressure of 35 if I were in the same situation.
Yeah,
I'm not sure, because if, you know, this is very common, like if there is pneumothorax, it actually will
absolutely.
the whole picture.
And it was quite disconcerting and scary, but you know, to give you the background, in labour ward, we'd put in a cannula, we'd give him vecuronium, with muscle relaxed. We had to get the chest moving, so it was very much a transitional thing. As soon as we got chest moving, but surfactant went in very quickly in labour ward, because we knew, you know, potentially this is a baby that does get into trouble. And then we managed to get the pressures down to 28 to 25, so 28 by the time we come upstairs. So for, you know, for a preterm large diaphragm, I think just getting them out of labour ward is sometimes quite challenging. And I think you can be permitted big pressures then if you've done everything else, like a big NG in the stomach, you've got rid of all the air, you've given muscle relaxant, you're not getting your saturations up, and it took those pressures to suddenly open things, and then we just came back very quickly. Yeah, but it's not a comfortable feeling, but we didn't start there. We worked up and worked up until we suddenly were able to recruit.
Excellent, thank you very much.
Anyone else, or is that us? We'd be interested in Neil's thought on the milrinone and adrenaline. We got the milrinone up to 0.5 as the BP came up, and I mean, do you feel that LV dysfunction, that's the right way to go?
Yeah, I think that's good. I like that combination. We start the adrenaline, the blood pressure starts to improve, and then we feed in the milrinone. Over the course of the next few days, the LV function's improved. I think probably is a natural phenomenon of improvement, but hopefully we've helped a bit in the short term with the adrenaline, and now the milrinone's up and the adrenaline is actually weaning off. It's just about to come off just now.
So it's always just a little bit different, you know, now a 32 weeker is just that thought, are we doing the right thing? But it seemed to help. And, you know, we did that, gave some volume, started the inotropes, and we were able to get our TO lines in later to get a better measure of things. Until then, it had been pretty impossible. So that's.
And the good thing about it, Anne-Marie, is just you keep monitoring with the you know, the scanning and the focus. So that's the beauty about it, because it's just available at bedside anytime.
Yeah, that's right. That's absolutely right. And actually, you know, just, you know, being reasonably reassured about that UVC, which is our central access, was great. So I'm going to go, I think, because we've got a pressure of other meetings. There's cardiac CME, and we've got a few cases to get through. So
I think, Abhijit, are you going to present a case
sorry,
as well?
do you want to? Okay, we'll get time
yeah.
to that. I wasn't sure. So that's
Yeah.
great. So pleasure to share those, and I'll let Abhijit
Thanks very much.
present.
Thank you, Anne-Marie.
Yeah.
How you wanted to do, Abhijit?
You might need to turn yours. If you want to leave the meeting,
Yeah, I will.
Otherwise we'll get some reverb on
Echoes, yeah.
Right.
Thank you so
okay.
much. That was great. Yeah.
Lovely. Good afternoon.
Hi, Abhijit.
Good afternoon.
Audible?
You are.
I'm not sure if I'm audible.
Yes, we can hear you.
Okay, great. I'll just share my screen now. How do I do full screen? This one, isn't it?
Yeah.
And then share screen. And this. Can everyone see my slide?
Yep.
Lovely. Yeah, so there was no any neither, I mean, I didn't had any diagnostic dilemmas of this case. It's just that I wanted to present what I have seen with the scan of these two cases. Right, so starting with this baby R. So this was a term-born baby with a spontaneously, vaginal delivery. There was no significant antenatal history. It was a straight off pregnancy, midwifery late care, up till the point when baby was about to deliver. At that point of time, had a severe brady, then apparently had a meconium stain and born lip at that point of time. So initial resuscitation done with IPPV and started on CPAP of 6 centimeter. Initially, oxygen requirement went up to quite high, 70 to 80%, but then quickly resolved to came down to 40%. With that, the saturations were more than 95%, and there was no pre or post-structural difference. So with this background, he was having quite a bit of a respiratory distress, grunting, I would say moderate intercostal and subcostal recessions at that point of time, and needing a considerably amount of oxygen. We did ask for the chest X-ray. Meanwhile, we thought we'll just do the lung scan and see how it looks. So this is R1 area, R1 zone. So you can see nice clear pleural line with interspaced by some broken areas, but yeah, mostly A lines intersected by the B lines. Similar sort of a picture in R2 as well. So normal, quite smooth and discrete pleural line with interspaced by broken areas where you can see shred sign basically. You can see A lines and which are sort of intersected by B lines. Going on to R3, I can see nice A lines, some comet tail artifacts, which are incomplete B lines. And then I can see some B lines as well. Quite discrete and smooth pleural line with some broken areas here again. Continuing this R3, trying to get get down to the liver as well. So I can see a discrete pleural line here, which comes up, but then there is quite a bit of a patchy area with a shred sign, completely broken pleural line. So that was on the right side. Moving on to the left side. Again, on the L1, which is the upper area, we can see nice and bright, smooth pleural line. It was well aerated, you can see, because there is a mirror image as well. You can see ribs on both the sides. So it's well aerated. You can see the mirror image, mirror image sign there. A lines intersected by the B lines. So that's L1. Now, if you look at the L2, it's completely a different picture now. I mean, it's broken pleural line, thick and coarse, completely broken. So you can see a shred sign. I would say static bronchograms there. So broken pleural line there. Moving along to L3 area, you can see a similar sort of a picture. So broken pleural lines, patchy areas, interspaced by some smooth line, but then mostly broken. And this is all the way down to the area of spleen there. So you can see quite massively broken pleural lines. So, this is a term baby, otherwise no significant antenatal history and born with a meconium stained Leica. So I was thinking at this point of time, because it's quite sparse. Oops. Sorry, I just lost my presentation.
So,
yeah. Sorry, there was my computer had a moment. Yeah. So with this background, basically, I'm trying to imply that, I mean, we suspected it could be a meconium aspiration syndrome, and by this time we got our chest X-ray done. So this was the chest X-ray. So this baby progressed quite nicely, actually. So within next 24 to 36 hours, the FiO2 requirement came down. So he was taken off CPAP once we knew it's a meconium aspiration. He was moved down to vapotherm, and within 36 hours, his FiO2 requirement came down to air. He was still chugging along, but he was able to maintain saturations without any support by 48 hours of life. So must be a mild meconium aspiration syndrome. Anybody want to comment anything on this?
Would you say that's quite typical meconium aspiration findings on the ultrasound object?
Well, to be honest, I haven't seen many.
Okay.
You know, with the
Yeah.
lungs, I haven't seen many.
Yeah.
It's a nice case abject actually, and it is exactly described like you have seen on your scan, areas of A lines intersected by areas of B lines. So basically you will see everything. You will see A lines, B lines, C lines, which is consolidation. So just for the people who joined, for our colleagues who joined just recently, to trying to explain what we found on ultrasound. So you look at the pleural line, which we had more prominent on the right side, but when we moved to the left side, we saw kind of interrupted pleural line, loss of pleural line in certain areas, with areas of consolidation, which is this kind of area surrounded by air bronchogram, which is a bright white areas because of air trapped in the bronchioles. And then you lose the air volume inside the alveoli. That's why you get this kind of consolidation bits. And we know from the pathophysiology of meconium, you have kind of plugging at different stages across the bronchial tree. So you get some areas over distended, some areas collapsed, and that's why you see this mixed pattern. So nice case. Yeah. Can I ask, did it cross your mind to give some surfactant at any stage?
Not really, because by the time we did the chest X-ray, we've been able to wean down his FiO2 further, and you know, given at the rest of the lung, which looks well aerated, it's mostly on the basal area, where we have seen this you know, segmental collapses there. We didn't thought about, you know, giving him surfactant at that point of time.
Yeah, nice one.
Yep. So moving on to next case. So this is baby M, again, term born in good conditions, ABGAs of 8 and 9, straightforward pregnancy. Given to mom, was found to be grunting in postnatal ward, and our colleagues were called to have a review. So initially, you know, there was 2 reviews involved where eventually it was decided to get the baby to the neonatal unit because there was worsening respiratory distress, and the gas was not sparkling at that point of time. So he was admitted and started on CPAP of 6 centimeter, and he was needing around 30% of oxygen. This was his chest X-ray done at admission. I would say, you know, it looks more like a TTNB sort of a picture with sunburst appearance, but nothing more than that. Looks like a well-expanded lung otherwise. Quite a big gastric bubble, but yeah, that's the first chest X-ray. And then gradually the respiratory distress keep on you know, increasing, and then he got a repeat chest X-ray done. So here you can see there's a good going air leak on his left side. So this was on CPAP, needing oxygen of around 40 to 45%. So again, we came in the morning on day 2 of life, when we knew already that he has got an air leak, and then we did a ultrasound just from the you know, academic purpose. So the baby wasn't kept in prone position. Sorry. So that's his right side. We can see nice pleural lines. With an eye of 8, you can see A line as well. Again, here we can see the mirror images. You can see the ribs on both the sides of the pleura, intersected by B lines. Coming to, you know, right posterior RP2 area. Again, you can see A lines. This area, again, completely B lines. There is no A lines whatsoever. So you can think about double lung point here. which again corresponds to he had a sort of a TTND picture on the first chest X-ray. Coming to the left side now. So this is what we saw on LP1 area. So you can see nice pleural line on the entire on the entirety. Some B artifacts, comet-tail artifacts, and B lines still here, but I cannot see any B lines or comet-tail artifacts in this section. And I can't see any pleural sliding as well. So it's difficult to make out on this small image here, but the pleural sliding should be appearing as a crawling of ant. I love to use that term. So it's like a ant crawling, which you can see here, but we cannot make that sliding movement over here. We did an M mode to interrogate this area, and this is what we found. So this is sandy beach appearance. So sky, wave, as in beach, and sand. So sandy beach appearance over the area where we see the B lines. And at the same time, we did M mode of this area where we cannot see the B lines, where you can see a stratosphere sign. So there's a transition from a sandy beach or seashore sign to stratosphere sign. Now this sign is pathognomic of air leak, whereas this particular image, what we are seeing here, whereas we can see a normal lung and where we cannot see any pleural sliding or B line, only A lines. So this particular image is called a lung point. When we move to LP2 area, you can see in entirety, there is no B artifacts or B lines. There is no pleural sliding. It's all A lines we can see here. So off note, we might not be able to see lung point, this particular image. If there is a big pneumothorax, we can only see image like this where there is no normal lung, and then just covering up till the splenic area. So it's all in entirety pneumothorax. So this I have just put as a comparison to see how the end crawling effect looks like in comparison to the pneumothorax where you can't see crawling of end. So here we can see B lines, some artifacts where this image is devoid of any B lines whatsoever. And you cannot see this crawling end effect on this, this image. And eventually, because the respiratory distress worsened, baby required intubation and putting in a pigtail catheter to drain the air. And we collected almost 30 to 35 mils of air. That's about it.
Terrific.
That's very nice.
Thanks very much,
you.
Abhijit. And that particular image is really useful to see the comparison of the area without the air leak and the area with the air leak. Yeah. And I think what was interesting about this case, because I was involved as well, is that based on the first X-ray, we thought this baby doesn't have a clinically significant air leak. It would look like a small air leak, but the baby was clearly deteriorating, was in more oxygen. And when we did this scan, we got the sense that the extent of the air leak was bigger than the X-ray. And exactly as Abhijit said, that's what turned out to be the case and was confirmed on a subsequent X-ray before the chest drain went in. So what I learned from it was to have confidence in what we were seeing on the lung ultrasound, and that there'd clearly been a change from the first X-ray, which fitted with the clinical picture.
Okay. Any comments from the audience?
No, thank you. They are beautiful. Thank you.
Nice one, Abhijit, as well. So it's really clear here in LP2 that you can't see, so the pleural is very, very static. And as you said, there are no B lines. So again, if you see B line in any particular area, that rules out pneumothorax 100%. So when you see it you're reassured. When you don't see it, you need to look for pneumothorax. So really good case, nice. Thank you.
Thank you. I think I have that's all for today.
Hi there. Hi, it's Hi, it's Jennifer Scotland here from Nine Wells. Sorry, do you mind just putting up the M mode ones again? I had I had my pictures of everybody in front of the wrong bit of the screen, and I'd really appreciate you just running through that again if you don't mind. Sorry.
Yeah, I can do that. Yep. Can you see it now?
Yeah, we can see it.
Yeah.
Do you want to go through the
okay, so this is so when we saw the lung point here, again, as Mahmood just mentioned, if you cannot see any B lines or cometal artifacts, you have to confirm that that area is having pneumothorax or devoid of any lung. So when we saw this lung point, where we can see a normal pattern here, pleural line, A lines intersected by the B lines, some cometal artifacts, and nice, good going pleural sliding here. Adjacent to the area where we cannot see any pleural sliding, we can see A lines, but there is no pleural sliding. There is no cometal artifacts or B lines. So we suspected this must be the area of pneumothorax. So we interrogated this area. So first we interrogated this particular area, which is normal lung. And here you can see the M mode of which, and in the normal lung, we should be able to see sandy beach appearance. So this is sandy beach, and it's a stretch of imagination, but that's the beach. And this is your, sea waves and sky. Mm-hmm. So that's normal appearance. And then we, at the same time, we interrogated this area as well, where we are suspecting there must be a pneumothorax. And when you do that, you lost this architecture. You see all straight lines here.
Okay.
And this particular area is called, this particular pattern is called stratosphere sign.
Right.
And in a stretch of imagination, if you look up the sky, in the clear sky, at the stratosphere level, you should be able to see clouds like this. I haven't seen it, but yeah.
or barcode sign sometimes.
Or barcode sign, yeah.
Really easier to see about that. That's great. Thank you very much. That's what I've got it now. Thank you.
Thank you.
Nice case. Thanks very much.
Thank you. Thank you.
Thanks, Abhijit and Marie and Neil.
Thanks very much, guys.
Thank you.
Thank you.